Hello friends, in today's presentation I will be talking about the Trans-Olecranon fracture dislocations. A lot of residents had asked me regarding the fixation techniques, the tips and tricks regarding the fixation of coronoid, how to expose it. So in this presentation I will be discussing all these points and try to simplify things as much as possible. So what is Trans-Olecranon fracture dislocation? So in Trans-Olecranon fracture dislocation, there is a fracture of the olecranon. Along with that, there are some additional fractures which result in instability at the elbow joint. There may be instability at the radiocapsular joint, or there can be instability at the ulnohumeral joint also. That means the relationship between the proximal ulna and the distal humerus is disturbed. So in this AP radiograph, you see some part of the proximal ulna is articulating with the distal humerus, while the remaining part is not aligned. That means it has subluxated. While the radial head and the capitulum relationship is also somewhat disrupted in AP view, but when we see the lateral view, the radial head is actually posteriorly dislocated. It should have been lying somewhere here. Now it is dislocated posteriorly. And this part is the olecranon. And this part, which is still in line with the distal humerus, is the coronoid. And this is the proximal ulna, which is fractured and lying in a posterior direction along with the radial head. So is there any classification for classifying these injuries? Right. So in proximal ulna fracture, we all know about the Bardow's classification, which is for the Monteggia fracture dislocations. So all have the fracture of proximal ulna, but in type 1 there is associated anterior dislocation of the radial head, while in type 2 there is the posterior dislocation of the radial head, and in type 3 there is lateral subluxation of the radial head, while in type 4 there is fracture of the proximal radius along with the fracture of proximal ulna. But the Trans-Olecranon fracture dislocations are more. That means here you see the ulnohumeral joint is still intact, while in Trans-Olecranon fracture dislocations there is disruption of this relationship. So to classify these injuries further, Jupiter had described the subclassification of type 2 Monteggia fractures, in which there is posterior dislocation or subluxation of the radial head. Type 2 Monteggia fracture dislocations were classified into 4 subtypes: A, B, C and D. In type A, there is a fracture of the coronoid along with the fracture of the olecranon. That means there is a fragment of the coronoid and there is a fragment of the olecranon. In type B, there is a fracture of the proximal ulna, but the fracture line is exiting anterior to the coronoid. That means the ulnohumeral articulation is still intact. That means it is not a Trans-Olecranon fracture dislocation. It is kind of fracture of the proximal ulna, which is just distal to the coronoid. In type 3, there is fracture of the proximal ulna, which is extending into the diaphysis. So you see here the fracture is extending into diaphysis. So this is also not the Trans-Olecranon fracture dislocation. It is a fracture of the proximal ulna, which is extending into the diaphysis and can have variable combination. And in type D, there is extensive combination which is extending from the diaphysis into the metaphysis as well. That can go up to the coronoid also. So this is a kind of Trans-Olecranon fracture dislocation, because there is a separate fragment for the olecranon and there is a separate fragment for the coronoid as well. So this is a kind of complex variety of Trans-Olecranon fracture dislocation, in which there is extensive combination extending till the diaphysis, and we have separate chunks of the coronoid as well as olecranon. So this is an example of Jupiter type 2A group, in which there is a coronoid fragment, there is an olecranon fragment. You see there is a coronoid fragment and there is a fragment of the olecranon also, and you see there is instability at the elbow joint. The radial head has subluxated or dislocated posteriorly. Now this type 2B, I told you there is no ulnohumeral instability, because the ulnohumeral articulation is still intact. The fracture line is just distal to the coronoid. You see the fracture line is coming till here. It is just distal to the coronoid. And I told you type 2C is not a Trans-Olecranon fracture dislocation, because it is nothing but the fracture which is lying in the metaphysio-diphyseal region of the proximal ulna. It is not involving coronoid, it is not involving the olecranon. Only there is subluxation of the radial head, which will get corrected once the ulna is aligned. In type 2D, there is extensive comminution at the diaphysis and which is extending into the metaphysis as well, and there is a separate chunk for the coronoid and the olecranon. Here you see the fracture is extending into the coronoid. This whole fragment is extending into the coronoid, and there is a separate chunk of the olecranon, you see. But you see, all these classifications were the subgroups of the posteriorly subluxed radial head, in which there is fracture of the proximal ulna with posterior subluxation or dislocation of the radial head. But these classifications do not classify the anterior subluxated variants. Here you see there is extensive comminution in the proximal ulna and radial head is actually subluxated anteriorly, so this part is not classified according to Jupiter. In this image also you see there is anterior subluxation of the radial head, there is a separate chunk of the coronoid, you see here, and there is a separate chunk of the olecranon, and whole of the ulna is subluxated anteriorly. So these were not classified as per Jupiter. In this image also you see there is extensive comminution here, there is a separate chunk of the coronoid. In this image also you see there is a separate chunk of the coronoid, and there is a separate chunk of the olecranon along with the extensive comminution in the metaphyseal region, and the radial head is subluxated anteriorly. So does the Jupiter classification give any clue about the fixation order or the approach or the techniques? No, it just classifies the anatomy of the fracture. So there is another classification, the Mayo's classification, in which there are 3 varieties with 2 subgroups. A means non-comminuted, B means comminuted, while the type 1 is undisplaced, undisplaced simple, and undisplaced comminuted. Then type 2 is displaced, displaced simple, and displaced comminuted. But these varieties do not have the instability at the ulno-humeral joint, while in type 3 there is unstable elbow joint. Why? Because the area which was having the ligamentous attachment is also injured. So in type 3 there is unstable elbow joint. So this is a good classification, but again the order of fixation and the techniques are not clear in this classification. So there came another classification which is much better than other classifications and which is justified by the biomechanics of the elbow joint that we will discuss in coming slides. So the Wrightington classification is a good classification that dictates the surgical planning as well. So if you see the proximal ulna and the proximal radius, the articulation looks like this. The ulna and radius are stabilized by the annular ligament, and this annular ligament is actually the part of the lateral collateral ligament complex. That means the ligament originates from the lateral condyle, merges with the annular ligament of the radial head, then inserts over the ulna here, and just behind the radius near the supinator crest there is a prominence of the ulna near the posterior part of the radial neck, which is meant for the insertion of the LUCL, that is lateral ulnar collateral ligament. This whole assembly is known as lateral ligament complex. And on the anterior side, this part, the coronoid tip, it actually provides attachment to the brachialis and the capsule of the elbow joint. So it is also the predictor of stability in antero-posterior direction. And on the medial side, this prominence you are seeing, this is the sublime tubercle. So the sublime tubercle marks the area where the olecranon merges with the coronoid. So this part is the sublime tubercle, the prominent one, and it is meant for the insertion of the medial ulnar collateral ligament. So it is the prime stabilizer of the medial side, and the anterior bundle is the strongest one. So whenever there is injury, you have to repair this part. So the Wrightington classification just describes this component. It doesn't tell whether there is fracture of the olecranon or not. It just tells about this component, whether this component needs fixation or not. So in type A, there is fracture of the anteromedial facet of the coronoid. So this facet of the coronoid is the anteromedial facet, and this part is the sublime tubercle. So whenever there is injury to the anteromedial facet, we have to fix it. The reason I will be telling in the coming slide. And in type B, there is bifacet coronoid fracture. That means either there can be a single chunk of coronoid that is having this part is the anterolateral facet, and this part that is the anteromedial facet. Either there can be a big chunk or there can be separate fragments as well. In this scenario, you have to at least fix the anteromedial facet. If there is a big chunk which is involving both the facet, that means you have to fix the coronoid either by plate, screw or transosseous suture repair. In type B+, there is a fracture of the coronoid which is involving both the facets, that means anterolateral as well as anteromedial, along with the radial head fracture. In such a scenario, you have to at least fix the radial head and fix the anteromedial facet of the coronoid. The anterolateral fragment, if it is a separate one, can be left. The reason again I will be telling in the coming slide. And in type C, there is fracture of the radial head, which is a comminuted one, or there can be a fracture of the radial head, which could be a simple one, along with the fracture of the anterolateral facet. But there is no fracture of the anteromedial facet. So it is purely injury of this region. So here also you have to fix the radial head minimum, and the anterolateral facet which is fractured can be left. In type D, there is a fracture which is distal to the coronoid, and it can be fixed routinely like we fix the proximal ulnar fractures using plates. And in type D+, there is fracture of the proximal ulna just distal to the coronoid along with the fracture of the radial head. Just kind of Monteggia fracture dislocation we had discussed. Or you can say type 2B fractures, in which the fracture line is just anterior to the coronoid, or type 2C fractures, in which there is fracture line which is in the diaphyseal region. And when there is fracture of the radial head, they will be classified as type D+. So there is no special steps required for fixation of these fractures. So in type D, we don't have any special technique for fixation of the fractures. It has to be routinely fixed like the proximal ulnar fracture and the proximal radius fracture. So now coming to the reason why we are following this kind of fixation priority. So the Wrightington classification is actually based on the column concept. So there is a lateral column which is the radius and the capitulum. There is a medial column, that is the anteromedial facet of the coronoid, the sublime tubercle and the trochlea of the humerus, while the anterolateral facet is actually the middle facet. So this part, anterolateral facet, is the middle facet. So the fulcrum of instability in elbow joint lies at the tip of the coronoid and at the junction of the anterolateral facet and the anteromedial facet of the coronoid. So we have to secure at least one column on either side of the fulcrum to keep the elbow joint stable. Therefore, if there is injury on the lateral side of the fulcrum, that means there is injury to the lateral column and there is injury to the middle column, that is the anterolateral facet, then we need not to necessarily fix the anterolateral facet. We just need to fix the radial head. This part can be left and there will be no stability at the elbow joint because the stability will be contributed by the anteromedial facet and the sublime tubercle of the ulna. Therefore, the isolated fractures of the anterolateral facet do not need fixation at all. And whenever there is associated fracture of the radial head, then definitely we have to fix the radial head only. There is no need for fixation of the anterolateral facet. So the column concept can be described by this diagram. You see the fulcrum is between the anterolateral facet and the anteromedial facet. Along with this, there is the ligament complex also, which is inserting over the sublime tubercle. So this is the medial collateral ligament complex which is inserting over the sublime tubercle, and on the radial side, or you can say lateral column, there is lateral collateral ligament complex which consists of the annular ligament and the lateral ulnar collateral ligament which inserts over the posterior part of the proximal radio-ulnar articulation, and this part is known as supinator crest, that is a prominence just posterior to the radial neck articulation with the ulna. I'll show you in the coming images. So whenever there is injury to the lateral collateral ligament complex, we have to definitely repair it. Whenever there is injury to the medial collateral ligament complex, or you can say medial ulnar collateral ligament or medial collateral ligament, then also we need to fix that. If there is fracture of the radial head, definitely we need to fix that, but the anterolateral facet can be left. It needs not to be fixed. While if the coronoid fracture is involving both anteromedial as well as anterolateral facet, then definitely we need to fix the coronoid fragment. But if the coronoid fragment is having isolated anterolateral fragment, then definitely we can leave this because the other column on the side of fulcrum is intact or has been fixed. And if there is isolated fracture of the anteromedial facet, then definitely it needs fixation. And we all are aware that the Olecranon fracture definitely needs to be fixed because that forms the major articulation with the distal humerus and is going to align the proximal ulna with the humerus. So that part definitely needs fixation. So this has been discussed. Anterolateral facet needs no fixation, and how to approach. So whenever there is isolated fracture of coronoid which needs fixation, that means the anteromedial facet or part which is involving the sublime tubercle. The sublime tubercle lies here. So that definitely needs fixation. But you see the difference between these two images? This one is having the Trans-Olecranon fracture dislocation. That means the olecranon also needs fixation. You just can't fix the coronoid alone. So in isolated fractures, we can definitely go for fixation of coronoid through a specific approach. But in Trans-Olecranon fracture dislocations, we have to approach in such a manner that all these fractures can be fixed through a single approach. So whenever there is isolated fracture of the coronoid which is not having olecranon fracture, then we can either put a plate or screw through the anterior approach. So all these fractures from type A to B plus Wrightington classification can be fixed through anterior approach. The Regan-Murray classification had described the coronoid fracture according to the size. Whenever that means the tip fracture, less than 50% fracture and more than 50% fracture. But this classification did not dictate whether it is specific for the anteromedial facet or the anterolateral facet. So it should be clear by now that anterolateral facet fractures need not to be fixed at all. So for anteromedial facet, we can definitely put a buttress plate or put screw if the fragment is small, and if it is very small, then we can do transosseous drill holes through this area and secure using fiber wire or ethibond suture. So these fractures without the olecranon fracture can be fixed through anterior approach, and the approach will be the Hotchkiss approach, in which we go over the top of the coronoid. The plane lies between the flexor carpi ulnaris and the palmaris longus. So we go in this area. We need not to isolate the ulnar nerve because that is lying in the belly of the flexor carpi ulnaris. So we have to create a plane between these two muscles. Then we will be able to expose this area. Then we can either put a plate or put a screw or make transosseous drill holes for securing the fragment if it is very small. The reason we are going anterior is because whenever we are going to fix this fragment, our direction of placement of implant or drilling is from anterior to posterior. Therefore, it has to be approached from the anterior. But if there is fracture of the olecranon also, there needs to be something different, which I'll show you in the coming slides. And for the radial head fracture, if it is associated with the coronoid fracture, then definitely we can go for additional lateral approach, which should preferably be the Cocker's approach. Why? Because through Cocker's approach, you'll be able to identify the rent in the lateral collateral ligament complex, and simultaneously you can repair it. So the type C fractures of the Wrightington classification can be fixed with lateral approach, which can be a Cocker's approach. Now the type D fractures, which are distal to the coronoid, and type D plus fractures which are having associated fracture of the radial head also. In all these fractures, we can definitely go for fixation from the posterior side because we can expose both the ulna as well as the radial head. So for radial head, we have to create a plane according to the Boyd's approach. That means between the anconeus and the extensor carpi ulnaris. So by that, we'll be able to expose the annular ligament. If it is torn, then we can definitely repair it. If it is not torn, and repair the radial head and then repair it again. And all column fractures which are associated with the olecranon fracture, in all these cases we have to go for posterior approach only because we have to fix the coronoid along with the olecranon fracture, and it will be difficult to fix the olecranon fracture through the anterior approach, which I have told you is meant for isolated coronoid fractures. So by doing the posterior approach, we have the advantages of multiple surgical planes. We can use the plane of Boyd's approach for exposing the radial head. We can use the Taylor-Shams approach for exposing the sublime tubercle of the ulna and the coronoid, and for placement of the implant on the medial surface of the ulna. For those who are not aware about this approach is actually going in this plane. That means you are just medial to the belly of the flexor carpi ulnaris, and you release that belly from the proximal ulna, and the ulnar nerve lies inside that belly. So you need not to isolate the ulnar nerve. So you'll be able to expose this much part by just retracting the flexor carpi muscle anteriorly. And for Boyd's approach, you have to go between the anconeus and the extensor carpi ulnaris, that is going to expose the radial head. So this plane between the anconeus and the extensor carpi ulnaris will be used for exposure of the radial head. Now coming to example. Now in this AP view, you see there is comminuted fracture of the proximal ulna, which is having olecranon chunk, and there is fracture of the sublime tubercle. Here you see this prominence is the sublime tubercle, and there is fracture of coronoid, which is not clear in this radiograph, and the radiocapitular articulation is also disrupted. We are not sure whether it is anterior or posterior. That will be commented on the lateral view. Now in the lateral view, you see there is a separate chunk of the coronoid, separate chunk of the olecranon. There is combination in this area, and there is anterior subluxation of the ulna as well as the radial head. This is the 3D image of the same case. You see there is a separate chunk of the coronoid. There is separate chunk of the sublime tubercle. This part is the sublime tubercle. It is meant for the insertion of the medial collateral ligament complex. And when seen from the lower part, end on view, this is trochlea, this is the medial epicondyle, this is the olecranon, this is the sublime tubercle, and there is combination here. The radial head is going anteriorly. And when seen from the radial side, again you see the radial head is going anteriorly. It is still articulating with the anterolateral facet of the coronoid, and there is combination here. And this part I've told you is the supinator crest, which is the area of insertion of the lateral ulnar collateral ligament. This part is intact and is in line with the remaining part of the ulnar shaft. That means the insertion of the lateral collateral ligament is intact. That's why the radial head and the anterolateral facet articulation is still maintained. That means the radial head is moving with the proximal ulna. It is not moving with the olecranon, or it is not dislocated posteriorly, because probably the lateral collateral ligament is intact. In this image also you see it is from the anterior side. The anteromedial facet and the anterolateral facet are a single chunk, while the sublime tubercle, which should have been lying here, is lying somewhere here. And the radial head is still articulating with the anterolateral facet at the area of sigmoid notch, but it is subluxated anteriorly along with the proximal ulna. So this was a fixation that we did, in which we had secured the coronoid through transosseous drill holes. That means drill hole was created in this direction, and it was secured with the remaining part of the ulna as well as with the plate. That means we have tied the suture to the plate and the ulna, so that the coronoid remains aligned with the proximal ulna. And this small plate is for the sublime tubercle. So you see this part which articulates with the medial part of the trochlea is the sublime tubercle, which we had seen in this image. This part is the sublime tubercle. So whenever we are going to fix this, if it is very small, then definitely we can use small suture bites through the insertion of the ligament. But if it is a fixable chunk, then definitely we can put 2 or 3 screws in this fragment using a mini plate, or you can say compact hand set plate, that will keep this fragment in line with the medial part of the remaining ulna. So you see it has been buttressed with this plate, and additional stability has been provided by screws which are close to subchondral bone. So this part is actually the sublime tubercle when seen from the lateral side, in the lateral view, and this is shown here in the AP view. So you see the articulation is now looking good along with the medial part of the trochlea, and the olecranon plate is going to address the olecranon chunk, and it will keep it in line with the remaining part of the ulna. Now as per the column concept, we have secured the coronoid, we have secured the sublime tubercle which is on the medial column. There was no separate fragment for the anterolateral facet, that is middle column. It was a single chunk which was having the anteromedial facet as well as the anterolateral facet. Therefore we had to fix the coronoid as a single block. So that has been fixed, and on the lateral column the radial head was not fractured, it was only subluxated, so it needs no fixation. And the lateral collateral ligament complex was found to be intact because I've told you it inserts over this part and it has not been fractured. So the joint remained stable after fixation of these fractures. While on the medial side, the medial collateral ligament was attached to the sublime tubercle, and now we have fixed the sublime tubercle, so there is no need for additional repair for the medial collateral ligament because it was inserting on that particular chunk only, that is the sublime tubercle. Now another case in which there is comminuted fracture of the proximal ulna. There is a separate chunk of the coronoid, there is a separate chunk of the olecranon, and the radial head is dislocated posteriorly, and there is extensive metaphyseal comminution which is extending into the diaphysis. So this is type 2D classification as per Jupiter, because there is posterior subluxation or dislocation of the radial head. So this is type 2D, in which there is separate chunk of the coronoid along with the combination of the diaphyseal region and with the separate chunk for the olecranon. So you see there is definitely a fracture of the olecranon, and the radial head is also fractured, but probably there is an impaction injury. We don't see a separate fragment here, only the shape of the radial head has been compressed here. It has become flattened in the anterior part because of the impaction, and probably some injury to the capitulum also. You see this part appears to be flattened because of the impaction, and probably these injuries need nothing to be done from the fixation point of view. And there is a large chunk of the coronoid, you see here, and this part, I've told you, this part is the supinator crest. It is also fractured. That means this is a kind of avulsion injury of the lateral collateral ligament complex, and probably that is the reason why the radial head and coronoid relation has been disrupted. Normally the radial head articulates with the sigmoid notch, which is just lateral to the coronoid. You see this smooth part is the sigmoid notch. Radial head should have been articulating with this part, but it has been disrupted, probably because this part is also fractured, which is meant for the insertion of the lateral ulnar collateral ligament complex. And probably there is some injury to the annular ligament also, because annular ligament starts here just anterior to the sigmoid notch, circles over the radius and inserts posteriorly to the posterior extent of the sigmoid notch. So probably that is also injured. So we have injury to the lateral column, which is comprised of the lateral collateral ligament complex, and some impaction injury of the radial head, which probably needs not to be fixed, because in this condition it can't be fixed. And on the medial side, we see again a large chunk of the coronoid, which is extending into the metaphysis. Some part of the sublime tubercle is still with the remaining part of the olecranon, while some part of the sublime tubercle is with the coronoid. Probably the ligament part would be intact, but displaced because of the displacement of this big chunk. What we can do, we can use transosseous sutures to pull this fragment towards the proximal ulna, and also we can use a small plate to stabilize this fragment with the proximal ulna. And this fragment is actually from the lateral side. As we had seen, from the lateral side is the area where the supinator crest is there. Probably this fragment is the fragment which has attachment of the lateral collateral ligaments. So we need to see intraoperatively whether it is having any insertion of the ligaments, and we have to secure this fragment either by plate, and if the plate is not possible, we can take some bites at the insertion of the lateral collateral ligament, and those sutures need to be fixed either to the ulna or the plate that we are going to use for fixation of the olecranon, as we will see in the coming images. So this fixation was done. Now the lateral column, the radial head could not be fixed because there was impaction injury here, while for this small fragment which was providing insertion to the lateral collateral ligaments was repaired using fiber wire sutures, and we had taken transosseous sutures through the coronoid also, that was pulled and secured to the plate, and also we had stabilized this coronoid fragment using a plate which was stabilizing this metaphyseal extension of the coronoid. And for olecranon, we had placed a routine olecranon plate, and we had secured a long screw which was going till the coronoid also. So a kind of good stability which has stabilized the medial column, that means the sublime tubercle and the anteromedial facet of the coronoid, and we have stabilized the lateral column also by repairing the insertion of the lateral collateral ligament complex which was inserting over that lateral fragment we had seen here. Now coming to the problems that residents have told me which they face for fixation of these injuries. First, the problem is the exposure of the coronoid through the posterior approach. It is very difficult, and when the coronoid fragment is small, it cannot be screwable or cannot be plated. How do we repair it? We can repair it with the transosseous drill holes and pull sutures through these holes. The sutures can be ethibond, or you can use the fiber wire because that is easier to pass through those holes. Then the problem is how to create those transosseous drill holes through the coronoid, and how to avoid injury to the ulnar nerve, and what are the main insertion points of the coronoid, and how to place a small plate for stabilization of the metaphyseal extension of the coronoid that we have seen in the previous image. These points will be discussed in a separate video because that video will contain graphic images and you will need to sign in to view that video. The link of that video is in the description. Thank you.